Good afternoon. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. Thank you all for joining us today and our friends at Horizon Healthcare in South Dakota for hosting today's session, What a Primary Care Provider Needs to Know About Chronic Kidney Disease. Dr. Wright was the medical director of the dialysis unit at Brooke Army Medical Center and director of the Nephrology Fellowship. Following his service with the Army, he went into practice with the Jackson Clinic in Jackson, Tennessee, where he established the nephrology service. During those years, he served as the clinic's chairman and then medical director. At Jackson Madison County General Hospital, he served as chairman of medicine, chief of staff, and a member of the medical staff quality committee. He also served as medical director for the Dialysis Clinic Incorporated facilities in West Tennessee for over 30 years. He co-authored the nephrology section of Rakel's textbook of family practice, as well as multiple medical papers. Dr. Wright, it's a pleasure to have you here today, and I'll go ahead and turn it over to you.
Thank you, Jill. Since I know you're in South Dakota, I assume that means everybody's eating lunch. I can't tell because I can't see you. What I'm going to do in the next 30 minutes or so is try to cover the basic points about care of patients with chronic kidney disease and the issues that have been brought about by some of the newer things that have come along in recent years to talk about these things. I've left plenty of time for conversation and questions at the end because it's been my experience that the questions you have are better than the ones that I might think you would have as I prepared the talk in advance. Before we get started, I need to point out that there are no conflicts of interest. There's no off-label use of anything being discussed. And this program is accredited by the AMA for 1 hour of contact. So my objectives for the talk, the part of this session, is for you to understand what the estimated glomerular filtration rate, which we'll call eGFR for short, tells you about your patient. Understand the importance of measuring proteinuria and what it tells you about the diagnosis, prognosis, and treatment of your patient. Understand the basic approach to delaying progression of chronic kidney disease in patients at risk using ACE and ARB, SGLT2, GLP-1s, I didn't put that in the slide, and finerenone. And then lastly, recognize your role in helping patients achieve a dialysis last or never as opposed to a dialysis first outcome. So let's start with a case. This is a case that's sort of typical of the way these things present. 36-year-old male was in a car wreck, got a laceration, went to the ER to get some stitches, had his vital signs checked and was found to be hypertensive on several occasions. Didn't come down with resting and recovery from the shock of the accident. He had some basic lab drawn showing a hemoglobin of 13.2 with normal indices, normal electrolytes, a BUN of 24 and a creatinine of 2.1. He's referred to you for follow-up of his acute kidney injury. So what are the questions you might have about this patient? Well, first off, one of the questions is this really acute? Remember, acute kidney injury is upcoding for hospitals. They can charge more for acute kidney injury than they can for chronic kidney disease. So there's a bias toward calling it acute. Sometimes when you try to find old lab values, which is the most useful and efficient way to find out whether this is new or not, is to see what it says in the past. And of course, W&L may mean within normal limits, but it also means we never looked. Things you want to be looking for if you have an old chart to go through, or if you have the patient in front of you, questions you can ask the patient. Were you ever really sick as a kid? Have you ever been told you had hypertension, maybe on a sports physical or a school physical, or ever have an abnormal urinalysis? Family history is more important than it used to be. We've always talked about family history in a general sort of way, but there are new observations about family clustering of CKD, which we'll get into. And up to 50% of CKD in kids has a genetic risk basis, and probably as much as 20 to 25% of adults, and it may be higher in some populations. While genetic testing and counseling are still not ready for prime time, in my opinion, you need to be aware because these are areas of active investigation, and one can always hope for new and more efficient therapies. The prototypical hereditary kidney disease is autosomal dominant polycystic kidney disease, and most of you have probably seen at least one patient with the story in the background. It's the prototypical hereditary disease of the kidney. There are two main genetic markers which go imaginatively as PKD1 and PKD2. There's a myth out there that says families have a typical time to develop end-stage kidney disease. So you're seeing a patient who's 30, who said, yeah, all the people who've had it in my family developed dialysis requiring kidney disease in their 50s. Not true. It has to do with ascertainment bias and a variety of other things. So everybody's their own control. Classically, they present with pain, hematuria, and enlarged kidneys, which can lead to a rapid diagnosis of cancer. I have, over the years, taken care of several patients who had a diagnosis of cancer, had one taken out, and was discovered to have polycystic kidney disease. With the better imaging techniques we have now, that's much less common, and I think urologists are more generally aware of the problem. So we don't see that as much as we did in the days when IVP was the main thing. There's some newer non-traditional markers, for example, apolipoprotein 1 subtypes, myosin and heavy chain 9 subtypes, both of which have higher frequencies in people with sub-Saharan African ancestry and in locations with high frequencies of endemic trypanosomiasis. The idea is that these abnormalities, which cause a predisposition to kidney disease, seem to protect you against infection with trypanosomiasis, so it has survival benefit. Let's stop for a moment and talk about the estimated glomerular filtration rate. Some of you are aware this has been a significant issue. It still gets confusing to folks, so let me try to see if I can make it simple. Measurement of glomerular filtration rate is central to diagnosis of CKD and is an indicator of timing for clinical decisions, which we now call stages. And most of you are familiar with stage 3, stage 4, stage 5, based on the estimated glomerular filtration rate. The current lab formula is based on a newer method, which has now been around for 20 years or more, for measuring creatinine to the second decimal point compared to the earlier versions, which only measured it to the first decimal point. There was a formula published in conjunction with the modification of diet and renal disease study. It was originally published with adjustments for Black race and all others. The formula has been changed and this reference has been eliminated, which caused some temporary changes in the estimated GFR in some patients. The point I want to make about it from a clinical point of view is to remember E equals estimated. It's not a real lab test. It's a calculated value that's based on the one that is measured, which is the creatinine. So if it matters, measure the GFR and consider whether you want to do a cystatin C or not, which is a non-creatinine-based measure for estimating glomerular filtration rate. Urinalysis is important, cheap, and readily available, but oddly enough, it seems to be the one test that doesn't get done and routinely in the clinic. We do blood work very readily and without too much difficulty, but apparently urine samples don't get done nearly as often because I frequently don't see any evidence of urinalyses being done on the consults that are submitted. Red cell casts are important but rarely seen. White cells typically cause people to write it off as a urinary tract infection. Now, urinary tract infections are certainly common and probably the most common cause for abnormal urinalysis seen in a clinic situation, but not everybody with white cells in the urine has a urinary tract infection. So if it's atypical, keep an index of suspicion in mind. Granular casts are usually nonspecific and related to proteinuria. Protein in the urine has been something that we used to talk about as a marker of disease, but we've come to recognize it's more complicated than that. We used to do a lot of 24-hour urines, and it's still the gold standard test, but it's hard to do in clinical practice. And if you're going to do it, you want to be sure to measure the urine creatinine so that you can index it. The average patient will put about 20 milligrams of creatinine per kilogram body weight per day in the urine and give you some estimate as how effective the clearance is. Labs used to do a urine protein creatinine ratio, but it's recommended now to go to urine albumin creatinine ratios. You can multiply by 0.6 if your lab doesn't do this and still come out with the same answer. But the urine albumin creatinine ratio, which of course is recommended in patients with diabetes, is a much more sensitive marker for what you're really looking for. The answer to the question, is this a therapeutic target? The answer is often yes. And we'll talk about why that's so, and particularly with the newer therapies that have become available in the last 5 to 10 years. Oops, sorry about that, it went one too fast. This slide has funny looking urine, albuminuria ratios of micrograms per minute. But the idea here is that there's a logarithmic relationship between the amount of proteinuria and the adjusted hazard ratio for cardiovascular disease. So by the time you get to really detectable significant amounts of proteinuria or albuminuria, you have a marked increased risk of cardiovascular disease. And this turns out to be clinically relevant because, as you'll see, this is one of the things that makes estimating what's going to happen more challenging. Predicting end-stage renal disease, what the patient really wants to know is, doc, am I going to need to do dialysis? Is always a key question. There are 4-factor and 8-factor models. The URLs are available on the slide deck, so you'll be able to look them up if you don't already have them. The 4-factor model works well enough and includes age, sex, estimated glomerular filtration rate, and the urine albumin creatinine ratio, and predicts the risk at 2 years and at 5 years. And if we think back to our initial patient, what you'd realize is that we don't know his urine albumin creatinine ratio, but I'm going to tell you it's probably low. So his 2 to 5 year risk of end-stage kidney disease is going to be less than 5%. So this is fairly typical. So you get an abnormal looking number, you get worried, is this something I need to worry about? The answer is it's something you need to pay attention to, but not necessarily something that requires emergent action. All the online equations overestimate the risk of end-stage kidney disease because of the competing risk of death from cardiovascular disease. Back to that earlier slide that we were just looking at. I had a patient one time when I was talking to him about these things, said, so what you're really telling me, doc, is your job is to keep my kidneys going long enough for me to die of my heart attack. And I said, yes, that's basically correct. Of course, I knew him reasonably well when we had that conversation. There are some other diagnostic considerations thinking back to our patient. Is this primary kidney disease or secondary kidney disease? More primary diseases have specific therapies such as minimal change disease, membranous glomerulonephritis, and rapidly progressive glomerulonephritis, but they need expert consultation and laboratory workup and probably a kidney biopsy. So these are patients you're going to want to refer once you get that far into the workup. Secondary in this country is mostly diabetes and hypertension, which is far and away the most common thing that nephrologists see, and far and away the most common thing that you will see in your clinic. Screening for collagen vascular diseases with things like ANA and complements is common, but may not be cost effective in the absence of clinical symptoms. Screening for cancer, which is associated with membranous glomerulonephritis in middle-aged adults, has the same problem. There are antibodies out there called thrombospondin 7A and about 25 others that have been identified as cancer-associated antigens, as opposed to PLA2R, which is in so-called idiopathic or primary membranous glomerulonephritis. But these are expensive tests and again, difficult to use. So something to be aware of, but not something that I necessarily think you should be doing in every patient. The other point I want to make is because MAVEN clinics serve a lot of people from a lot of places. Syphilis, hepatitis B and C, and HIV are reasonable in the population, and malaria is probably the most common cause of disease worldwide, but obviously is uncommon in the United States. So think about where your patient's from and what they may have been exposed to before they got here if they're immigrants. So what I've said so far is genetic factors are important, particularly in patients of African ancestry. Proteinuria is important. Albumin is better than proteinuria, although I use the terms interchangeably in this talk for both diagnosis and prognosis. Kidney failure risk equations are available to estimate 2 and 5 year risk for kidney failure, but overestimate the risk because of the competing risks of coronary artery disease. And I'm going to say it again because I'm going to say it about 4 times before we get through. Remember, the eGFR is an estimated GFR. It's useful, but as a guide, not an absolute. The patient's clinical status still matters. So what can you do once you decide this patient does indeed have chronic kidney disease and you need to be doing something about it? I'm going to talk about several things: blood pressure control, diabetes control, avoidance of nephrotoxins, particularly non-steroidal anti-inflammatory drugs, and probably proton pump inhibitors, and proteinuria reduction, which is where the ACE and ARB come in, the mineralocorticoid receptor antagonists, the SGLT2 inhibitors, and the GLP-1 agonists. And I'm sorry for all these abbreviations, but all of these refer to class effects in my view. They're not specific to a single drug in the family. Let me share some thoughts with you on hypertension. ACE and ARB are desirable. Cost and hyperkalemia can be issues, particularly with the ARBs. Volume control is a key issue for controlling blood pressure, particularly in patients with CKD stages 4 and 5. And you generally need to use a loop diuretic. I typically use furosemide because it's cheap and readily available. as thiazides don't have much effect once you get to CKD 3 or greater. The exception to that may be indapamide in a patient with no evidence for volume expansion, and maybe the add-on of chlorothalidone late in the end stage, again, usually done in patients who are already on a loop diuretic. And remember, so-called diuretic resistance occurs commonly in patients with nephrotic syndrome. The loop diuretics work from the luminal side of the membrane, so using a drug like metolazone in a situation where there appears to be resistance is additive, probably because of a direct action on the distal convoluted tubule. Is there a blood pressure target that really makes sense? This is the SPRINT final report, which has been out now for almost four years. 9,361 patients, big study. And hypertension with increased risk of cardiovascular disease, no diabetes, no stroke, and were randomized to intensity, meaning a systolic blood pressure goal of less than 120 versus the usual or standard goal at the time of 140 with a mean follow-up of 3.3 years. The composite event rate was 1.77% annually in the intensive group versus 2.4%, which usually gets reported as something like a 35% relative risk reduction. But the absolute reduction is 0.63 events per year. So you have to treat about 159 patients to get one benefit in a composite event rate reduction. It's not an argument not to do it. It's just to be aware of what these kind of numbers that give some clinical oomph to the question of what's going on. All-cause mortality was 1.06% versus 1.44% annually, which means there's an absolute reduction of 0.38 deaths per year, which means you have to treat 263 patients to prevent one death. Adverse effects also went up. Hypotension was 2.1% versus 1.2, syncope was 2.1 versus 1.6, and acute kidney injury was 4.1 versus 2.5, which is an absolute reduction of an absolute increase of 1.6 episodes per year, where the number needed to harm was 63. So the point I'm trying to make here is that although these are guideline recommendations and ones that might be sensible in the average healthy 40-year-old, whether they make sense in an 82-year-old grandmother is a different question and one that you have to ask. It's because the conclusion is clear that lower targets have lower event rates over the intermediate term, but at the cost of increasing complication rates. So as always, it's a matter of patient selection, and you have to consider tolerance, competing risks. And I like to say we're fond of the more is better theory of medical care. That's certainly been true of hypertension, where in my career, the goals have gotten steadily lower, but it's rarely true. And remember, aging occurs in everyone, albeit at different rates. The goals for medical care change with age and comorbidity, so you need to keep updating. Your patient may have been a good candidate 10 years ago, but maybe not such a good candidate now. Acute kidney injury is noted as common, particularly with the use of renin-angiotensin system inhibitors. Studies show 30 to 50% relative risk reduction for end-stage kidney disease in patients with eGFR greater than 30 by and large. And since the absolute risk is 3 to 5%, which means the absolute reduction over 5 years, you got to treat about 100 patients over 5 years to get somebody who doesn't start dialysis. And the question that comes up commonly in the consult file from folks in MAVEN clinics is, I've got this patient with two questions. One is that I've got this patient, I've already got them on ACE inhibitors, and they still have proteinuria and their kidney function is still getting worse. And a corollary question is, they're still getting worse. Should I stop the ACE inhibitor? Is it making things better or worse? This is a question that's so common, it's actually been the subject of studies that I want to share with you. But a couple of things before we do that. The first is to remind you the relationship between creatinine clearance and the serum creatinine is an inverse curve. So small changes in the creatinine down here make large differences in the creatinine clearance. So, because here you're going from 1 to 2, and you've gone from being normal to somewhere around 50%. And as you get worse in here, you got lots less change in creatinine clearance, but much greater changes in the serum creatinine, the numbers that would alarm most of you. Second thing to bear in mind is that the kidneys manifest what's been termed autoregulation. And if the mean arterial pressure is generally somewhere between 60 and 160, that's at the level of the kidney, not necessarily in the arm. You have stable renal blood flow over that entire range. But if you get too low, you begin to lose autoregulation, just like you do when you get too high. So with these two physiologic facts in mind, what do the data show? Here's a study from 2022 that looked at 411 patients in the United Kingdom with CKD 3 or higher who were randomized to stop or continue their blockers at 3 and followed for 3 years. Bottom line conclusion is among patients with advanced and progressive chronic kidney disease, the discontinuation of the RAS inhibitors was not associated with significant between group differences in the long-term rate of decrease in the eGFR. It occurred in a fairly large number of patients, as you can see in the rest of the slide. The number of deaths was about the same. Well, that prompted a second study. If one's good, two's better. This was a meta-analysis looking at the question of stopping in advanced chronic kidney disease, and a meta-analysis of 18 trials with 1,739 patients with a mean eGFR of 22. The hazard ratio for risk renal replacement therapy with continued inhibition was 0.66, meaning it was less. There was no effect on mortality risk and no observed interaction with age, glomerular filtration rate, albuminuria, or diabetes. So what it says is that if the patient's kidney function is progressing, there's no particular reason to stop it just because they're on the ACE inhibitor. It doesn't seem to be exposing them to increased risk of kidney failure or death to do that. So which study is right? Kind of depends. These are the slides from that study, and you can see the curves look similar but different, and you can't see that very well. So let me just give you the conclusions. Lower blood pressure targets have lower event rates over the intermediate term, but at the cost of increasing complication rates. I said that before, I'm saying it again. ACE and AARB are recommended, may be beneficial in advanced CKD, but as always, it's a matter of patient selection. I said that before too. It's not that I'm getting senile, I'm repeating myself on purpose. We're fond of the more is better theory, but it's rarely true. So keep that in mind as we look ahead too. Well, what about SGLT2 inhibitors? This is the DAPA CKD study from 2020, which is now almost 5 years old, which was 4,304 patients with or without diabetes with an estimated glomerular filtration rate between 25 and 75 and a urine albumin creatinine ratio between 200 and 5,000. So these are people who had significant diabetic nephropathy. Composite endpoint was a 50% reduction in eGFR, need for renal replacement therapy, or death. And the trial was stopped early when the hazard ratio was 0.56%. Death occurred in 101 patients on the drug, 4.7, versus 146, 6.8% on placebo. So here again, as you can see, over a period of 3 years roughly, you've got a reduction in risk of death on the order of almost 2%. What do we call it? 2% to make it even. So the number needed to treat is 1 in 50. So this is a much more powerful study than the ACE inhibitor study. Renal protection seems additive when in patients with established diabetic nephropathy when combined with ACE or ARBs. It's limited at the moment by the package insert to an eGFR of 25. Studies are underway to see if it can be safely continued lower than that. I think expert opinion right now would suggest if the patient is doing well and not having trouble with hypoglycemia, you'd probably want to continue the drug at least as long as you could for the benefit that's associated with it. Remember, it is associated with a natriuresis that causes an osmotic diuresis with glucosuria. That's probably why they're particularly useful in patients with heart failure with reduced ejection fraction, but it's also associated with acute kidney injury, especially since you've got the patient on an ACE or an ARB at the same time. They're costly, and again, it's a matter of patient selection. Would an SGLT2 be better than a GLP-1 for somebody's heart disease while you're trying to treat the kidney disease? It depends is the real answer. Forniase gangrene has been reported and associated with SGLT2 inhibitors, as are urinary tract infections in general, and they got a lot of negative press, but is it overblown as a risk factor? It's bad if you get it, but so it has an anchoring heuristic associated with it, but it may not be a major thing as we use smaller doses. Published last year, by the time I was getting ready to give this talk last year, a study was published looking at a GLP-1 on chronic kidney disease in patients with type 2 diabetes. Another big study, 3,533 patients with an eGFR of 25 to 50, urine albumin creatinine ratios of 300 to 5,000. followed for a median of 3.4 years. Primary outcome was major kidney disease events, a composite of end-stage kidney disease or eGFR less than 15, a 50% reduction in eGFR for baseline or death. 24% relative risk reduction in the treated group, mean decrease in eGFR was 1.16 milliliters per minute lower rate of loss compared to the control, and a 20% lower relative risk of death from any cause. Now, I haven't gone to the trouble of calculating the number needed to treat on these folks, but you can see again, the data are presented as relative risk reduction, not absolute risk reduction. One of the interesting things about the the GLP-1 inhibitors to keep in mind is something that I wasn't aware of before this study came out, so I like to share it with you. You'll notice up here in the first year or so after randomization, the patients who were being treated with semaglutide did worse than the patients who were on the placebo. The benefit didn't really kick in until somewhere about 2 or 3 years in. The reason for this is not clear. Some people think it may be related to the weight loss. Some people think it may be related to intravascular volume depletion. The real answer is we don't know. And since we don't know, we argue about it a lot. But on the other hand, be aware that sometimes things get worse. And it isn't necessarily a reason to stop the drug. If you had a morbidly obese patient who's getting benefit from his heart, it probably would matter. The most recent study that I've seen, which I've not put into a slide, suggests that continuing the GLP-1 inhibitors is associated with improvement in cardiovascular risk, although probably not renal risk. So it's backwards from the SGLT story where the renal benefit stays, but the heart benefit does not. Blood pressure control with ACE and ARB help delay progression. The goal is debatable, but the guidelines recommend sprint targets using standardized blood pressure measurements, not usual care blood pressure measurements. So let me make a comment about that. What they did in Sprint was they brought patients into a room with dim lighting, put headphones on them, kind of like the ones I'm wearing, played music of their choice, usually quiet, soothing stuff, not hard rock, and took automated blood pressures at 15 minutes. It took 3 15-minute blood pressures, gave them plenty of time to adjust, and they took the average of the three as their usual blood pressure. Now, I don't know how it is in your clinic, but in my clinic and the ones I go to for myself, I walk in some variable distance from the waiting room to the doctor's office, sit on the table, and may or may not have my feet crossed, and get my blood pressure checked pretty much randomly by a person as opposed to a machine. Turns out if you compare those two numbers, it turns out the difference is usually about 10 millimeters of mercury systolic. So if you take a patient who got usual care blood pressure measurements of, let's say, 130 over 80, they may really be already at 120 over 80 anyway. The SGLT2 inhibitors are the hot new kids on the block. As they become more widely used in both diabetic and non-diabetic disease, you're going to see more studies that are going to help clarify the benefit and the risk. The GLP-1 antagonists also display, I said agonists, not antagonists, also delay deterioration in diabetic nephropathy. And finerenone, a drug we haven't talked about, which is a synthetic aldosterone antagonist, has similar benefit in diabetic nephropathy in the so-called Fidelio study, but hasn't become widely used yet because it typically is associated with problems with hyperkalemia in patients who are already prone to it. And I think people just haven't really quite bought into the idea that it makes that much difference. But again, this is one you can expect to see new studies on and new guidelines. Let me shift gears because obviously we've been talking about delaying chronic kidney disease so far. And it could delay what? What are we trying to accomplish? Well, we're really trying to avoid having to do renal replacement therapy. And as I said to that patient said to me, what you're really trying to do is let me die of my heart disease as opposed to my kidney disease. And the answer to that is yes, most patients would prefer that. I've taken care of a lot of people over 1,500 on dialysis at least over long term, and very few of them thought it sounded like something they wanted to do. They're difficult medical regimens even for the best patients to follow. They involve restrictive diets, complicated drug regimens, dialysis either 3 times weekly if you're doing hemodialysis or daily if you're doing peritoneal dialysis, and clinic follow-up for transplants with lifelong medications. So the questions I would like you to think about when you're seeing your patient is your patient a candidate? And what can your patient expect on average? Turns out these are the prevalent ESRD by modality through 2021. The data always lag. The new ones will be out shortly. They'll go through 23. And you can see that the prevalent patients are on hemodialysis, which is the green line going across the black line going across the top. The green line in the middle is home hemodialysis, which has gone up some. And sorry, the red line, I'm having trouble talking. Peritoneal dialysis, which is this line, has gone up some. And transplant, which is I can't even see my own color, which is the green line, has gone up some too. So the number of patients out there with these disorders has increased. So you may see some. Point prevalence overall has gone up, which is what this slide shows. What the patient really wants to know is this slide, which is what's my risk of dying. And you can see that back in 2011, the average risk of dying for all hemodialysis patients was somewhere around 17, 18%, and had gradually improved by 2019 to about 16%. So we thought we were making progress, but lo and behold, COVID came along and messed things up, and we've got a jump and a blip in the data. And so far, we've not seen those data return back to baseline. We're still dealing with an excess mortality, probably related in some way to COVID, maybe long COVID, not known for sure, and the data aren't available. It's possible that if we look at 2 or 3 years, it'll all be back down here in the 16% range. So a question that would come to your mind, of course, is when should I be referring to a nephrologist? If the patient's sick, of course, you're going to want to send them to the ER or to the nephrologist. If the patient shows an active urine sediment, renal biopsy and aggressive therapy may be considered. That means somebody with lots of red cells, white cells, and protein in the urine. If the urine protein creatinine ratio is 660 or the urine albumin creatinine ratio is greater than 300, you might consider referral. It's a little less urgent there. In the patient we started with, referral is not urgent. He does need a urine albumin creatinine ratio for determining his risk. And remember, as a nephrologist, I don't have any tools for medical management that you don't have in your clinic. Monitoring lab quarterly is helpful to get an idea of the tempo of disease. But something like 80% of patients with a stage 3 chronic kidney disease will not progress to stage 4. Only time will tell. So you aren't necessarily in a hurry to send all patients with stage 3 disease. If you've been following them fairly regularly and you know they've gone from stage 2 to stage 3 over the last year or two, you may think they're going to do worse. But again, it's one of those things where there's some time for you and the patient to have some conversations and to consider what else might be going on. I do have to make a few comments about what the government refers to as the undocumented alien. This slide was written before the current administration took office, so this is not to be construed as a political statement. Dialysis care is funded mainly by the government, which refuses reimbursement to this group of patients. Some hospitals get disproportionate share payments that may provide for emergency treatments, which is defined as pulmonary edema, severe hyperkalemia, overt uremia, but not routine dialysis. 40 of the 50 states have some kind of emergency care program. I happen to live in one of the 10 states that does not. Two positions. One, regular dialysis is the standard of care and is the just approach. The other position says, do we have the right to spend other people's money? Can't propose to give you the right answer to that because I don't know that there is one, but it is the question. And you need to know what's going on in your state so you know what the options are for your patient. And I don't know offhand what's going on in South Dakota, so you might can tell me. So what we said is when working up a patient with newly discovered elevated creatinine, remember to assess proteinuria and a urinalysis. Treat hypertension as close to 125 over 80 as you can get without side effects. Use an ACE and ARB, and you may need to use a loop diuretic. Remember, the EGFR is just an estimate. This is the fourth time I said it, and I've done it on purpose. It should generate thought, but not necessarily action. As the primary provider, you have a role to play in assessing your patient's suitability for dialysis. Have a real conversation and don't take the view that, of course, you'll do dialysis when the time comes. No dialysis is a viable option in the right circumstances. So with that, I'll stop, get a drink of water to get rid of the frog, and talk to you about what's really on your mind. And I see we do have a few questions already, Jill.
Wonderful, Dr. Wright. Thank you so much. And just wanted to encourage everybody If you have any questions for Dr. Wright, you can either put them in the chat or use the Q&A icon on your Zoom toolbar, and they can be general questions, or if you have a patient in mind and you want to ask something about that, please feel free to do that. So here's a question. A patient with mild high blood pressure, always well controlled, found to have a creatinine of 1.5, the estimated GFR in the 40s, urinalysis with small RBCs, thought to be due to the prostate, no casts, otherwise healthy. How to treat and what is the prognosis? The patient is 78 years old.
He'll die of something else. He won't die of his kidney failure. He's a perfect example of what I've been trying to talk about. His 5-year risk of end-stage kidney disease is very low, probably 1 or 2%. And it's more likely because he'll get run over by a truck or shot by a jealous lover and end up developing acute kidney injury as a result. As to what's going on, in addition to prostate disease, you always have to vaguely worry about things uh, like IgA nephropathy and things of that sort. But I don't know if in a 78-year-old guy who's getting along okay, I'd leave well enough alone. Let's put it this way. If it's me, I'm going to be leaving it well enough alone. And I'm close enough to 78, I can hear it from here. So
Great, thank you. Here's the next one. Can you go through additional workup for newly elevated creatinine? What are the labs, imaging, and when to refer to the nephrologist? I'd love to hear your clinical thoughts on that.
So the basic thing is you got to figure out, is there a diagnosis you can make? If the patient already has diabetes or severe hypertension, you think might be related. Hypertension is kind of a chicken and the egg problem because patients with kidney disease get hypertension, patients with hypertension get kidney disease. Knowing which came first is always difficult. So the question as to how far to go is dependent on resources. But the things that I would do would include a urinalysis, basic chemistry profile. At least once, I would probably do a renal ultrasound to look for kidney size, position, make sure they got 2 kidneys, don't have obvious cysts, don't have any obvious obstruction, things of that sort. So I think that it's the kind of thing where that's the basic workup. I don't usually recommend an extensive serologic workup unless you've got somebody who's got nephrotic syndrome of new onset, who isn't diabetic, who doesn't have any obvious explanation for what's going on, because the yield is low and you won't change what you're going to do. Kidney biopsies are one of those things that kind of depend. I think with some of the newer therapies that are out there, kidney biopsies may be experiencing a small resurgence, but there's a resistance to doing kidney biopsies because most of the things that we deal with are going to turn out to be treated with the things we've talked about already: ACE inhibitors, ARBs, SGLT2 inhibitors, those kind of things. So conservative, non-specific therapy is still the hallmark. Now, the academic nephrologist would go, "Oh no, we've got all these new therapies. We got to be doing all these tests." And talking patients into a procedure will give you a weather forecast. You got an 80% chance of developing end-stage kidney disease in 20 years, which would be the most common thing in an adult. It's not very helpful. It doesn't lead to major therapy. And some of the serologies are useful. So the distinction you want to be making is this patient got nephrotic syndrome or not have nephrotic syndrome? If they just have abnormal creatinine, is it obstruction? Is it something else? Is it progressing rapidly? Is it progressing slowly? If you plug these into the kidney failure risk equations, you'll get estimates that are very low. The lower the protein, the better the prognosis as a rule. I don't know if I've answered the question, but that's my off the top of the head response.
Great, thank you. The next question, how about secondary bone metabolism labs such as vitamin D, PHA, PTH, and how to manage?
Okay. Okay, here's where I'm going to get really iconoclastic. Okay. The guidelines say you should be checking vitamin D levels and administering vitamin D and phosphate binder therapy and all that kind of stuff. If I ask a group of experienced nephrologists, well, how many years on dialysis does it take to develop metabolic bone disease? The answer typically is they've never seen it develop significantly in patients with less than 5 years exposure on dialysis. If I ask the second question, which is how many patients do you expect to have alive 5 years after they start dialysis, the real answer is 20%. the 20% are disproportionately congregated in the young, otherwise relatively healthy folks. And guess who are the hardest bunch of folks to take a bunch of extra pills when they don't want to? The same young, extra healthy folks. So what I would do is I would try to worry about the phosphorus levels, and particularly in patients who have advanced CKD 4 and 5. I wouldn't worry particularly about vitamin D levels. I've not become an enthusiast for it, but somewhere toward the time when they're getting close to dialysis, they probably will be started on it. And I think a lot of the data on this are skewed by the research bias of the people who are interested in studying this. As a clinical problem, when you got it, it's terrible. I've had a number of patients who were reduced to a wheelchair, but these are 25-year survivors on dialysis, and I'm not sure we could have prevented it. And I'm not sure we can measure all the hormone levels that are valuable. We can measure PTH and vitamin D levels relatively easily, but PTH levels are influenced by the degree of kidney failure, so interpreting them is a challenge. FGF23 is hard to measure, but maybe just as important. And who knows what else is going on that we still haven't discovered. So metabolic bone disease is a distraction from my view from focusing on the things that make a difference in terms of slowing things down. If the patient is complaining of proximal muscle weakness, thinking about metabolic bone disease and vitamin D therapy may be a reasonable thing to do, but the typical average well-nourished patient, I don't worry about it very much at all. But that's not the board review answer to the question. That's my answer to what to do in the clinic.
Great. Thank you so much, Dr. Wright. And just wanted to encourage any more questions to come in. And while I'm waiting to see, I wanted to just give a little refresher about our MAVEN Project community portal, where any of our partner clinics can submit consults through an email consult, an e-consult, or a video consult request and get advice from our MAVEN Project volunteers. So I'm going to go ahead and show you the home page. So all of you should have your own MAVEN Project account. If you don't, you can email me and I'll put that in the chat and let you know how you can get your MAVEN Project account. This is our home page. Check out our community news feed. We usually put something new about once a week. Sometimes it's a tip about using the portal. Sometimes we'll highlight a particularly interesting consult that may have come in from one of the other provider clinics. And then we also have spotlights about our MAVEN Project volunteers, and then also clinical pearls that are always really interesting to read. So you'll go to your medical consults, and I'm just going to give you a reminder or show you where you can find a list of all of our about 70 specialties and subspecialties. So you can scroll down and see all of these specialties. You'll see in the upper right of each box, it says if it's adult or if it's pediatric specialty or primary care. We actually have a complex cases room, which is really interesting. So since today is our focus on nephrology, I'll go ahead and show you the nephrology group, and we'll scroll down, and here's nephrology. And you can actually see here's Dr. Wright. So we have 4 MAVEN Project nephrologists, and they're happy to help you with your patient questions regarding the kidney. And you can click on each one. You can read about their bio and their clinical interests. If you can make a request to a specific volunteer if you like, or if you don't know who you want to ask, you can just click first available, and then the consult kind of goes into a round robin and gets assigned to a particular volunteer. And you'll usually get a response back within 48 hours and sometimes less than a day. So just wanted, our volunteers are really eager to help you, and don't feel shy in asking your question, whether it's small or a little bit more complex. So I'm going to go back to questions. When looking to add on Finerone, how do you decide? If the patient's already maxed out on an ACE or an ARB, sometimes the patients feel like, oh gosh, man, another pill to add.
Agreed. Fatigue and pill burden are a real phenomenon. So it's like what I've tried to hint at, you have to try to decide what's my goal of therapy. If I got a patient who's progressing and already, in spite of fairly high doses of ACE inhibitors, SGLT2 inhibitors, and so forth and so on, am I really going to gain very much by adding yet another pill with side effects, or am I only going to increase the likelihood of hyperkalemia? And I think you have to sort of answer the question, you and the patient together have to sort of decide how you feel about that. I'm kind of a therapeutic minimalist myself. I tend to typically think that most patients want to minimize the number of pills and minimize the disruption. And the risk of adverse effects now has more value or more economic weight, if you will. It's more real than the delayed risks of something like dialysis, which is more theoretical and in the future. So the discounted value of future events, if you will, is a real phenomenon. And everybody's different on how they feel about these things. So if you had somebody who was really terrified of dialysis and was willing to do almost anything to avoid it, probably give it a try. If I had the typical patient who's somewhat more philosophically resigned, I might not.
Great. Thank you. I'll just wait another maybe 10 seconds and see if there are any other questions. And these have been fantastic questions so far, so I'm very impressed. Great. If anyone has any, further follow-up questions, you can definitely reach out to Dr. Wright through the community portal and even submit a consult to him. And Dr. Wright, thank you so much for the great talk today, and to all of the providers and attendees for listening in. And a huge thank you goes out to our partner clinics. You guys are doing amazing work. Please don't forget it. Your patients are really lucky to have you. And MAVEN Project and our Physician Volunteer Network is here to support you. If you need advice, a second opinion, a curbside consult, if you just want to learn more, we're here for you. And so I hope everybody has a great rest of your week, and we'll look forward to seeing you at a future session.